if compromised. And so all of that is super duper important to continue to stress. We know that people are so fatigued right now with all of the messaging around COVID. Even our healthcare workforce and our public health workforce is really experiencing a lot of outbreaks on the one hand and a lot of fatigue / apathy on the other. And those two are combining to create local outbreaks that I'm sure you're aware of and that we're having more and more experience with at public health and some of our other facilities as well. I guess the one saving grace is that school is out. So there are some students in schools, but not as many as it when the school year is in. And so I think that is honestly helping to some extent because we know that schools are another place where really high transmission rates kind of perpetuate a vicious cycle. So for what it's worth, hopefully we will be through the worst of this by the time school comes back in August. That's really what we're hoping with fingers crossed. And at the same time, there's some things on therapeutics and vaccines that I'll be talking about, which will hopefully give us another tool in our toolbox. We have so many tools in our toolbox to put this behind us. And I hope that we can all work together to really implement these strategies in a way that's evidence-based. So one of the newest tools in the toolbox is the vaccines, which are now approved for really anyone that's 6 months and older. We have Moderna and Pfizer that's available for 6 months through age 4 years. That's as of last week. There were some announcements by the CDC working with the FDA and then also the CDPH working with the Western States Scientific Review Work Group. And they really are all giving thumbs up to Moderna and Pfizer being used for 6 months and above, either through emergency use authorization or something equivalent to that. In terms of what these look like, Moderna and Pfizer are a little bit different. The Moderna is a 2-dose initial series and the Pfizer is a 3-dose initial series. They have a little bit different dosage in terms of micrograms. As you can imagine, these are not the same as the adult dosages so that they come in different colored vials and things like that. So if you are vaccinating, which we hope that many of you are, or will be interested in it, and I will share a grant program about how to get involved. If you are vaccinating both adults and kids, just remember you're going to have to do some logistical safety planning to make sure that you don't mix up the dosing, but it's nothing that you can't handle. It's really just basic safety practices related to the fact that these doses are different from each other and also from the their adult counterparts with Moderna and Pfizer. You can read the rest of this table. It really just reinforces that the vaccines are safe and effective and that we don't have a lot of long-term data, but there's nothing to suggest that things will surprise us at this time and that adverse events are minimal and within the realm of what's expected with vaccines, things like low-grade fevers, et cetera. This is a little bit prettier slide that just shows you when these doses will fall, depending on the age group and depending on the product that's used. For whatever reason, no one really knows why, maybe because 2 doses are more attractive than 3 doses. People are really gravitating towards the Moderna right now, and that's totally fine. There's plenty of supply. If you go to the My Turn site, and hopefully one of our communications team can put that in the chat if you need it. But the My Turn site is really your one-stop shop for everything related to vaccinations because it can really get your patients and you information about where to go to get your vaccinations. And you can just punch in your zip code, your age, et cetera, and then really get an appointment just over the internet about where to go. For immunocompromised, you're going to have an extra dose in general, regardless of age, and that's shown on this slide. So this is for immunocompromised children, and then for adults, this is summarized in this slide. Hang on just a minute. The only thing that is a little bit different from Fresno County, this is a CDPH slide that I'm sharing. The only thing that's a little bit different from Fresno County is that whereas nationally and at the state level, people recommend 1 booster and a 2nd booster for certain high-risk groups, what we've done in Fresno County is gone ahead and said, really, if you're in healthcare, you're high risk enough to where we want you to have a 2nd booster so that you can have extra protection in your frontline work. And so that's basically a memo that you see in the bottom right of this slide that you can print out and show to your vaccine provider, whether that's a clinician or a pharmacist or some other clinic that you go to. And that really, they should honor that and say, that the Fresno County Health Department has gone ahead and given permission for people who seek a second booster, provided that they're a healthcare worker, to go ahead and get it if they're under age 50 or not immunocompromised. And hopefully some of you will take advantage of that. I know that took us a while to get out there, but now that it's out there, please use it. I think that it's really one of the great things that we can do to protect our understaffed workforce and really get them the full protection, because we know booster immunity wanes, and we know that these variants are going to find weaknesses in our armamentarium. And some people will feel a little bit better if they have an up-to-date booster, even if they're under age 50. So it didn't make sense to us why the 50 age cutoff was put in there. And so that's why we created this memo. And we're happy to answer any questions that you might have about that policy. Okay, any questions so far? This is just a slide that the state shared about preventing administrator errors. Just to, like I said, the volume is different, the cap color is different, and some of them require diluent while others don't. And so really, you should be working with whoever's giving your vaccines so that they understand all of these distinctions. And just make sure vaccines are clearly labeled and organized in your fridge, so people don't accidentally grab the wrong vials, because that does happen. It's not the end of the world, but the more that we can do to prevent that, the better, because it obviously is very stressful for patients, families, and staff to have a medication error like that. And so whatever you can do to prevent it would be great. Now, if you're interested in providing vaccines, or you just feel after our many weeks of telling you that you should be part of this, guilty enough to jump in the game, there's actually an incentive program that the Physicians for a Healthy California is sponsoring, which is $10 million to support grants to get primary care providers to become vaccinating places. Knowing that primary care providers and pediatricians are really where people get the most trusted information about their medical care. Whenever they have a medical home, they just do better in so many different respects. And we really want more primary care doctors to be part of the infant and toddler vaccination campaigns, because we feel like parents will really respond to that much more than just going to, a stranger at a pharmacy or even pop-up events where they may or may not be able to make those hours. Going to a provider, having the time to sit down with someone that they know, a trusted authority, a familiar face. These are all things that are going to help tip some of the people that are on the fence about getting their child vaccinated. And the PHC, the Physicians for Healthy California, recognize that and have set up this grant program, which is going to end in just a couple of weeks. So please, you can click on that link and find out all about it. It's a pretty painless application, and it can really kickstart your vaccination resources if this is what's preventing you from being a vaccinating site. And obviously reach out to us, whatever we can do to help in terms of lending technical assistance, expertise, logistical support, really any mentorship. We're more than happy to do it because we have a lot of experienced staff at public health that have been doing vaccines for almost 2 years now, and we're happy to help you. All right, any questions about COVID? Sorry, I didn't get to talk about therapeutics in particular, but just remember that there is also a lot of therapeutics that are available in the form of IV remdesivir, but also oral medications such as Paxlovid and Molnupiravir, and also the monoclonal antibodies. And just keep in mind that there's a locator that the federal government has provided that can actually help you locate by zip code where the closest pharmacies and prescribers are for those medications. But again, any of you who are prescribers on this call, you can actually prescribe these oral medications provided that you go through some of the precautions and contraindications and things like that So it's not hard to do, and it's really something that we need more people to be doing, because these are, again, very powerful medications that will keep people out of the hospital. And we really have an equity issue where the most vulnerable populations are not getting, not taking advantage of all of these different tools that we have in our toolbox at this point. And yeah, thank you so much for sharing that test to treat locator, Sim. That's in your chat. All right, let's talk about monkeypox. Okay, so this is something that I'm really learning a lot more about. I'll be honest with you, I didn't know how seriously to take this, but the more I learn about it, the more I understand that this is most likely circulating in Fresno County, and we just haven't seen our first case yet. So I just want to urge you all to be vigilant, and I will hope that the next few slides will prepare you to recognize and respond to that first case of monkeypox that I know is going to happen just in the next few days to weeks. So this all started back in May. Monkeypox is endemic in some African countries, but it really was discovered in the UK and Europe and the US starting in May of 22 for this outbreak. And these were really men who have sex with men identified in sexual health clinics. And on May 17th, there was a resident of Massachusetts who developed an anogenital rash, which then spread to cover the face and the trunk as well. So that's kind of how it started in the US. Catching everybody up, as of yesterday, the total number of international cases is 4,896. And they're from 65 different countries. In the US, there's just over 300 cases from 28 states. And here you can sort of see that California has a few dozen cases, but they're really spread out over many different states all over the US. In California, there are 79 cases from 12 counties, not including Fresno. There have been no hospitalizations or deaths. Really, all of them 100% currently are patients that have a sexual history of men who have sex with men. Although this disease is so contagious that sexual contact is not necessarily required. It can actually be contracted just through touching the lesions or sharing fluids. So there's a real concern that this is going to kind of stray out of this lane of MSM and really start affecting people's family members. And then really once it jumps into heterosexual sexual networks, then it's really just going to spread through all different demographics, as it were. And so even though right now this seems to be, just a disease of gay men, just like HIV was initially thought to be, this is really thought to be something that is probably underdiagnosed and will soon be a disease that anyone can catch just with intimate contact of lesions, which has been well described for prior outbreaks of monkeypox, the way that it is spread in African countries. Again, the risk factors include international travel, close or intimate contact with a known case, and participation in venues. So there's some people who they had no idea who got it, who gave it to them. They had no known case contact, but participation in, venues where you have multiple sexual partners, conventions where these sorts of activities take place, et cetera, have all been described during this outbreak as linked to these cases that are now popping up. In terms of what's going on with the epidemiology, here you can see that, throughout June, there was just this low level increase, and you can argue that it's actually going up now at the end of June. And now with this holiday weekend coming up, that's expected to continue. It's actually showing up in the wastewater, which is very interesting. So we've shared wastewater information with you about COVID. Now this is actually something that is being used to do surveillance in several different counties, including San Francisco and San Jose. So that's super interesting, is that this could be another very early surveillance tool that we bring to bear, so that even if a county doesn't have any cases being reported, if they see wastewater evidence of monkeypox, then they know that it's basically circulating. I don't have many details about how much wastewater surveillance is actually being done, but I'm definitely very interested to hear how that data is going to develop. And if somebody on this call, if one of our epidemiologists has more information, please jump on and clarify. Most had lesions in the genital or perianal areas, but other lesions are definitely possible, and I'll show you some gross pictures in just a minute. Prodrome has been mild or absent. So that's another kind of atypical presentation of this, is that sometimes the lesions happen first, and then sometimes they get systemic symptoms like rash, lymphadenopathy, flu-like illness after the rash kind of erupts. All of the ones in California have had mild disease, meaning that they didn't require hospitalization, but some have been treated with an antiviral called TPOXX, and I'll explain more about that in just a minute. And then some have actually been offered post-exposure prophylaxis with a vaccine called Jynneos, and we actually have some doses on hand just at the ready, just in case we hear about close contacts or cases that require post-exposure prophylaxis. What are the clinical symptoms? So this sounds a little bit redundant, but just to kind of hammer it home, this is going to look like a lot of other STDs. This is going to look like a lot of dermatological conditions that are frankly very boring and get rushed out of the clinical practice because they're thought to be very benign. Please take that extra pause to ask yourself, could this possibly be monkeypox whenever you see an exanthem, whenever you see lesions in different phases of development? You really shouldn't be seeing very much chickenpox, although it is out there. But if it looks like chickenpox or herpes, you should also be considering monkeypox in your differential at this point. The rash can be scattered or diffuse. Mucosal areas like the anogenital region or the lips and the face are definitely higher risk. Anorectal pain and tenesmus, proctitis. These are all kind of telltale signs of monkeypox in the hundreds of cases that have been described across the US. And like I said, prodromal symptoms may be mild or deceptively absent until after the rash actually happens, which is very unusual for monkeypox. Usually the prodromal symptoms, like in the African patients, happen before, okay? And you gotta rule out other STDs because again, it's gonna look a lot like other STDs, and just given the high risk activities that a lot of these patients are doing, they're definitely at risk for chlamydia, gonorrhea, syphilis, herpes. One of the patients that the CDC shared had chlamydia co-infection with monkeypox. And here's the gross pictures I was talking about. And I urge you to go to this COCA call. I'll share you a link. I'll share you a link later in the slide set. It's a 1-hour webinar, and it's like definitely worth your time. And it's kind of riveting to watch the one case that they feature and how they did the contact tracing and how they figured out where this gentleman had been and really how his rash evolved and was treated. It's definitely worth watching just for a really good explanation of exactly how this happens in real time. But as you can see, some of these rashes they look like molluscum to me. Sometimes they look like disseminated gonorrhea, which we've talked about before on this call. They may or may not have central umbilication. They may or may not have scabs and even look like ecchymosis in some of these pictures. So they can have a wide variety of different presentations. And I'll just leave this for you to review on your own time. In terms of the lessons learned, this is from the CDC call. Got to take a complete sexual history. You just got to close the door and really just ask them, hey, I need to know everything about what's been going on. Who are your intimate partners? Where have you been? This is really important for us to do good contact tracing to help protect the people in your network and to find people that may also be at risk. The rash can begin in mucosal areas. Sometimes you don't see the umbilication early on, and sometimes you don't see the prodromal symptoms till after the rash has been seen. And then this patient, like I said, the one that they presented was co-infected with chlamydia. So just that was a lesson learned for them, that they really have to do a broad sexual disease workup. And then he brought in his partner, and his partner actually just had folliculitis, but folliculitis can look a lot like these lesions. And they did a lot of testing on him, and he ended up not having monkeypox. He ended up having folliculitis. So that was another lesson learned, is that this can look like MRSA lesions. that cause folliculitis as well. Now, what do we do to treat monkeypox? Well, there's vaccines and then there's treatment. The vaccines come in two flavors. One is called Jynneos and the other one is called ACAM. Everyone agrees Jynneos is probably safer, but this is probably not the right forum to do a deeper dive into a full comparison of both of those. The CDPH has actually given us 20 doses, which it's a 2-dose vaccine. So that's 10 courses of the Jynneos product. So we have that in one of our fridges down in the health department. There's also just a lot of the ACAM available, but it's got a little bit higher risk of things like myopericarditis. You can actually auto-inoculate. So if you like rub the area of the vaccination and then rub your eye, you can have a really bad outcome. So auto-inoculation is a real problem because it's a live virus. So the ACAM vaccine, like I said, is less desirable at this time. But if there's a huge demand, if this really mushrooms into a situation where we need to be vaccinating a lot of people, then we're going to be relying on both of these vaccines. And you heard earlier this week, the White House actually did, not that there's any other problems to solve for the White House, but they actually had to sit down and do a press release about the fact that they're responding to monkeypox. And they did. And they basically said, we have 50,000 vaccines that we're releasing right now. And we have about 500,000 that we are already ordering from overseas to have available in the next few weeks. So they're taking it very seriously. You're going to hear more and more about these vaccines being available to more and more people. And I'll explain how that's being triaged right now. On the other side, there's also antiviral treatments. So there's something called tecovirimat or TPOXX. There's an immunoglobulin for vaccinia. And also there's an antiviral called Cidofovir. And there's also other kind of experimental antivirals in the pipeline that are probably all going to come into play, depending on what else is going on with the patient, if they're immunocompromised for things like HIV, or if they're super sick and having to be hospitalized, then they're going to need more aggressive treatments. And so I think you're going to hear about more and more treatments being given to some of these monkeypox patients, just depending on what else is going on. So surveillance and containment are really, so remember back in the early days of COVID, we were really trying to do containment. And basically that's kind of what's happening here with the early days of monkeypox. And we're really just trying to isolate cases, do aggressive contact tracing, even texting people on their phones to tell them that they may be an exposed contact and that they need to go see the health department right away. And then really figuring out who needs vaccines either as pre or post-exposure prophylaxis. I'm not going to go through the details of this. These are all slides from the COCA call. So like I said, please watch the COCA call where they do a deep dive into each one of these 4 squares and then talk about all the different considerations that the CDC will make whenever they make their recommendations. And obviously this is, very much a moving target. The TPOXX is an antiviral treatment. This has been approved for human smallpox. However, it's not approved for monkeypox by the FDA, but you can actually use it under an investigational new drug or IND, expanded access protocol, which requires like an IRB and a more or less academic trial being done. So there's 3 centers in California that have currently done this, and they've given it to 11 patients, and they all had good responses. So UC Davis, Cedars-Sinai, and UCSF are all doing this. They're now wanting to recruit more sites, and us being, a large county in the Central Valley, we're really at the top of their list of having a site for this TPOXX antiviral treatment. So that could be an academic center, that could be a community clinic, or a hybrid academic site that has an STD clinic. Please contact us if you're interested in this. I'm trying to get more information from the state to just say, like, how painful is this IRB procedure going to be? How much work do we have to do as local jurisdictions? Obviously, we want to have all the tools in our toolbox that we can to help our patients. But on the other hand, we need to know more before we enroll for something like this. But if this is you, then please reach out to us. We would love to have a site that we can send patients to, in the same way that we have many different sites at this point for our monoclonal antibodies for COVID and for our antivirals for COVID. This could be, we could set up a network of sites for antivirals for monkeypox. We just need to all work together. So please reach out to us if you're interested, or if you see a lot of patients that are in this population already and higher risk, then we definitely want to hear from you. This is something else that the state is doing. They're going to text people and scare the bejesus out of them. They're basically going to say, hi, this is CDPH reaching out about an important health issue. You might have monkeypox. Please call us back. So just keep in mind that this is not in our control, but it is something that the state is going to unroll, and it's probably going to cross multiple county jurisdictions. And so just something to give you early warning about that your patients may be getting text messages from the health department. We will try to, address these as appropriately as we can, but this is really something that's kind of outside our wheelhouse at this point. It's really something that they're actually using AWS, which is the Amazon cloud service. So if you didn't think Amazon knows everything about you, then you're absolutely wrong, because now they're going to know this too. Doesn't that just make you feel great about where we're heading? All right, any questions so far? All right, so in terms of vaccines, there's going to be pre and post-exposure prophylaxis. Pre-exposure prophylaxis is really going to be for lab workers that deal with like the swabs and the lesions, and you can see, they may be dealing with hundreds of samples every day. And if some of those get aerosolized, this is actually a very contagious infection. So even if they're working under a fume hood with full PPE, they still need an extra layer of protection if they're working with this dangerous virus. So lab workers and preparedness workers are probably going to be first up for pre-exposure prophylaxis. Post-exposure prophylaxis is going to be for those that are at risk because they've contacted patients that have monkeypox. That might be clinicians on the front line that had a monkeypox patient but didn't use PPE. That might be families of patients that just live in the same household. And then obviously sexual and intimate partners of patients that have been diagnosed with monkeypox. So that's kind of the larger kind of delineation of pre and post-exposure prophylaxis for these vaccines. Again, the limitation on doses is going to be the big bottleneck. There are more doses expected, but right now there's only 56,000 doses for the whole country. California got 8,000. And like I said, Fresno County got 20. So that's kind of what we're dealing with, is the demand is probably going to far outstrip the supply for the first few weeks to months. But then, that's why it's important for us to do the surveillance and everything else that we can in order to contain this outbreak. Just to give you a diagram of how the testing works, what you need to know is just call this number. This is our communicable disease investigators number, 600-3332. Please correct that for me, Sim. I'm going to correct it right now because I think that's so important. I apologize. And basically, this will get you in touch with our communicable disease investigators, and also, okay, now it's corrected. And also give everyone kind of a case to open, basically. So once you call that number, that kind of opens a case for us, and then we contact the lab, which is in Tulare County. There's other labs as well, but the lab that we use is in Tulare County. And we basically arrange for the testing to get sent down to Tulare County to have them run the monkeypox testing, which is a two-step process. First, they check for just general orthopox viruses. And then if that comes back positive, then they check for a specific type of orthopox called the monkeypox. And so that's kind of how the testing gets done. It's two-step testing, and it can't be done at any hospital or clinic. It has to be sent to a regional lab, which is called an LRN lab. And that's basically how the CDC is doing it throughout the country. Other diagnostic testing, like I said, for STDs, et cetera. If you have to send the patient home before all this happens, that's okay. Just get a good phone number on them, get a good list of do like a contact tracing real quick, the way that we used to do with COVID, and get their sexual partners and their intimate contacts. Really have them start running in their memory, like who have you slept with or who have you been with, et cetera. Swabs from 2 to 4 sites, if they have visible lesions, are very helpful. And then check for other STDs, which you can probably do in-house or send them out the way that you usually do. And I would say RPR, gonorrhea, chlamydia, HIV, and herpes are all things that should be almost universal for this patient population, especially with the presentation that's very concerning for monkeypox. Okay, so that's kind of what you need to know. The takeaway is, I think monkeypox is here. I think it's circulating in Fresno County, and I think many cases are still undetected. You may see it very soon, so be vigilant. Remember to ask the history just to get a good list of contacts and to really do that risk assessment based on history. It is very contagious, so you need to have good PPE. That means a good N95 mask, which you should be wearing in your clinical encounters anyway, as well as eye protection and really a full gown if they have disseminated rash or exanthem. Remember to check for other STDs. Remember to call that number and then use a synthetic fiber swab and just put it in like a urine specimen cup or a dry sterile cup. It doesn't need any kind of medium or anything, but don't use wooden swabs. And try to get multiple swabs so that they can test for, like I said, it's a two-step process, and they can also test for a few other infections as needed. So it always helps to get multiple swabs so that we don't have to bring the patient back. And really, you should swab them before you send them out. That's super important because sometimes these patients are lost to follow-up, or there's a delay and they're spreading the infection, et cetera. So, as soon as you can swab them, that would be best so that we can get this process started. If the LRN lab approves of our testing request. Any questions or any information that any of my colleagues want to add? I certainly will humbly submit, I'm still learning all about this. So for those of you that have had, close cases or, brushes with this, we've certainly had a couple that we thought were monkeypox. And we called the state hotline and we kind of did the whole thing. And it turns out that they weren't monkeypox. So we're still waiting for our first case. But we learn something every single time with even these close calls. And so we appreciate hearing from you earlier rather than later.
Well, Dr. Vohra, as always, you do a fantastic job covering so much information in a really short period of time. And just in terms of monkeypox, some of the biggest differentials there, they're vesicles. So as you mentioned, and they're mainly anogenital, so certainly herpes, but varicella is the other one. So and then monkeypox. So all of those can be tested by doing those swabs through PCR testing. So PCR basically detects the antigen for those viruses. Those are kind of specialized tests, and one of the things that CDC said is they were going to be making the testing more readily available through commercial labs. So hopefully that happens. If so, you should be able to swab for all three of those, and with this, the same, going over those same lesions. If they actually take the scab off, then that's okay as well. They can test from that also. So you said the most important point, which is to get the swabs of those lesions before they leave. But again, HSV, VZV, and monkeypox PCR will cover the most important differentials.
Great. Thank you so much, Dr. Zweifler. Yeah, the one gal that we had, apparently, she had a disseminated exanthem, but she also had cats that she was like fostering. And I think the cats had some kind of ticks or mites or something that were causing little bites in her skin. And that was creating a dermatitis. So that was the ultimate diagnosis for her. But we kind of, went through the whole chain where we called the state and we really ran this case past them. And they really weren't interested because she wasn't an MSM. She didn't have the demographic and the sexual history. Even though she had a drug use history, she just didn't have a sexual history that was convincing enough to them to do the testing. And it turns out that it wasn't monkeypox. So.
Well, and CDC has changed its guidance. At first, they said you needed to have both the lesions as well as the epidemiologic link, i.e. being in a high-risk group. But now they have dropped the and component of it. So it does really open it up to a lot of other people. But what we've seen so far is that really has been in individuals with involving sexual contact. So that's certainly the highest risk group. But again, as Dr. Vohra said, reach out to Fresno County Department of Public Health at that number that's listed, and we will noodle through the cases as they come up with you.
Yeah, and Lupe asked a good question. Does the swab go to the county? So it actually goes to Tulare County because our lab doesn't have the capacity to do this testing for the general orthopox PCR. And so that actually just goes to Tulare County from what I've been told. But there's other regional labs, there's a Richmond lab, there's other labs down in Southern California. So as long as you get in touch with us, we can actually patch you through to which lab needs to get it. We can actually help facilitate the transport as well. So our team does that all the time for all kinds of other testing. And so all the labs kind of work together. Just the key is to have public health in the conversation. And we're trying to streamline that as best as we can with a single phone call for you to call. Great question. All right, I can't stress these COCA calls enough. The CDC, God bless them, have done just amazing work with many different topics. So this is what the website looks like. This yellow box takes you to this website. So please click on that whenever you get this PDF. And there's different calls from the last few weeks that are really worth your time. So, I would say go through this holiday weekend. You can listen to the monkeypox. It's probably not G-rated, so don't do it around your kids, but it's definitely worth your time to just learn about it. It's an hour long, but it's an hour that's very well spent, especially if you're on the front lines and are seeing populations that may be affected. Definitely worth your time because it's very well done. Then you also have COCA calls about the vaccines. So all the things that I just said about the 6-month-old and over getting approved for vaccines, they actually have a COCA call related to that. Then they have a COCA call related to what if your patient has COVID, or what if your staff have COVID, or what if you come down with COVID? What do you need to know about the therapeutic options and how do you navigate through those? And lastly, just a general overview of monkeypox. This is a couple of weeks old now and something that moves as quickly as this. These statistics may not be as relevant now, but they do a deeper dive into the history of monkeypox and what's known about it from around the world and in historical outbreaks. So that's also worth your time. But really all of these can be found on this one website. And so please go to those COCA calls. They're all done by the CDC, by the national experts in all of these topics. There's a couple of AFLs, all facility letters from the CDPH that I thought might interest you. There's one about hospice agencies, facilities, and other stakeholders. The CDC is having a the Center for Healthcare Quality is holding a stakeholder meeting to discuss hospice regulations. So if you work with hospices or have hospice patients come to you, or if you're in a nursing home, for example, or work with a nursing home, then you may want to just tune into this to hear what the issues are. This is always good to kind of just have a seat at the table sort of thing and just listen to what the issues are and where things are going with hospice regulations. Another one that's probably even more important is that there's a bunch of different things in the California Code of Regulations which are changing. This is due to different state laws that have been passed recently. And these affect general acute care hospitals, psychiatric hospitals, skilled nursing facilities, prison clinical facilities, and also many other outpatient facilities. It's a 30-page document, and every single page of it has something changed. And they basically therefore made dozens of changes in the CCR, and it's now open for comment until September. So please take a look at it. It's not only important for you to kind of voice your concern if there is any concern or support or suggestions, but it is a good deep dive into all the different areas that are covered by the CCR. And all of that is covered in this AFL, and the actual document is at the bottom at the second link. I found it super interesting, and I hope that you will too. But it really covers just a broad variety of things in many different healthcare facilities. So you may want to just take a look at that and see if there's anything that concerns your practice. That's it. I think we have time for discussion. Have a safe and happy July 4th. Chris Staub from the Blood Center reminds everyone to please help with their constant need for blood donations. Please donate blood if you yourself have the capacity to do that. And if you don't, then please urge your staff and your patients to donate blood. And you can watch this YouTube video, which is a PSA that they just made. They actually have a raffle to go to New York City for people that are donating blood. So that's all described in this YouTube video that I'll leave for you to watch for your own enjoyment. Otherwise, have a safe and happy 4th of July. Stay cool out there. I think this heat wave is almost over and will be over by the time the 4th of July happens. Hopefully we will reconvene in a couple of weeks and catch you up at that time. But I'm open to questions if you have any. Thank you. I'll check the chat too. All right, Sim has put in a bunch of great links into the chat. Thank you so much, Sim. And I will send out the slides right after we adjourn today. Any other questions or comments? All right. Well, thank you all so much. It's always great to hear from you and to check in with you. Like I said, hopefully you get some nice R&R time over the holiday weekend, and we'll see you in a couple of weeks. Thank you so much. Take care.